part of your learning, okay, because you're now moving on to the next step, which is you're taking physiology, which we taught you in the first semester, and now we're moving to the next step, which is really going to allow you to understand the disease process and then formulate a plan and give the appropriate anesthetic for that patient. Okay. Now we're going to go a little bit into a review first, and then we're going to go into more pathophysiology stuff first. Now the first thing you want to do is when you start trying to get an understanding of pathophysiology is you have to get the basic anatomy down. Okay, so this is going to be the cardiac section. So we're going to talk about pretty much about the heart. Okay? Now one way of looking at it is from an anatomical failure point. Okay? So if you have some component of the heart that's going to fail, that will result in certain pathophysiologic disease process. The next thing we're going to also discuss is the other way, which is the functionality of the heart. Okay? And that's a very important clinical way of looking at things, which is every time you consider the heart, you have to say to yourself, what's the preload, what's the afterload, what's the contractility, and what's the heart rate. Okay? If you start developing that kind of thinking process, you don't have to memorize signs and symptoms. Instead, you can understand the physiology and the pathophysiology that will result in the signs and symptoms that you see clinically. Okay? It's much more difficult, and trust me, I had to do this myself because nobody told me this up front. I memorized all the signs and symptoms and then went backwards. That's not the way to learn, okay? Because you're going to be confused. You're going to say, well, there's no correlation to anything. This is why you see it, okay? And you start seeing just patterns. That's not really what happens, okay? Form follows function. Disease is caused by some breakdown in the system, which then results in the signs and symptoms that you see in the human being, okay? So if you understand that, it makes it a lot more manageable, and then you begin to try to, so when you see things clinically, you can figure out how to fix it. Okay? So looking at it from the anatomical point of view, you can look at the heart as having a fibrous tissue component, which it does. It doesn't have a skeletal component like a bone, but it does have fibrous structures underneath it, which holds the actual muscle in place. These are the sinospiral muscles, which I'll show you here in a minute. They're not really cartilage or anything like that, but they are very heavy-duty, like tendinous structures that hold things intact, including the valves. The surgeon disrupts these when he's doing a valve replacement. It's a disaster. The valve then will not seat properly and it will flop when the heart pumps. So that's not something you want to see. The next and more important component is for the actual workload is a cardiac muscle. And you have to think of that as a contractile component. And then when you look at this concept, you have to go down to the cellular level and think at what's the normal voltage for a cardiac muscle cell. Minus 85, okay, because it's going to do work, okay? And the wave pattern that's generated by cardiac muscle is very different than the rest of it because it's going to generate that rapid upstroke with a nice plateau phase, phase 2, and it's going to drop back down, okay? Now, the next portion of the heart, which is something that we weren't taught till approximately about 10 or 15 years ago, is actually the elastic component of the heart is very important. The ability for the heart to relax properly and to dilate appropriately is becoming increasingly more important in our understanding of what happens in ischemia. Okay? If you do not have good tissue elastance, the ventricle becomes very stiff and as a consequence can't accept filling properly. And if you lose your atrial kick in that situation, it can become very clinically deleterious. The next set of cells that you're looking at are the electrical activators, which are the pacemaker cells, and that includes your conductance capacity cells. These usually run at minus 60 to minus 65 millivolts because they're not trying to do workload. They're doing just signal transfer. Okay? Now, what's really interesting about the heart, and they're very different than the skeletal tissue, is that the heart works as what's called a syncytium. Okay? It's a big word. Okay? What it really means basically is that the cells are not connected via axons. Okay? They're connected together via what's called gap junctions, which are proteins that attach cell to cell. The importance of that is that once a pacemaker activates, it doesn't have to send a neuronal transfer telling it via neurotransmitter to activate. What the pacemaker does is it fires off electricity around it, and the surrounding cells, which are attached via gap junctions, will then get activated, okay, depolarized, and they cause the whole heart to depolarize all at once. You can actually take a heart completely out of an animal, or a human actually, and you can actually put it in a petri dish and put enough of a good electrolyte solution, enough sugar and ATP, and you activate it by just touching it, and it'll continue to pump all by itself. It has an intrinsic pacemaker capability, and it'll go on for a long time as long as you give it nutrition. Okay? That's pretty neat. It doesn't need an autonomic system, in other words, what I'm telling you. Which is kind of good because otherwise heart transplants really wouldn't work very well, right? You'd need a pacemaker in all those people, which a lot of times we don't. Okay? The valves form the heart into separate chambers. Some valves are much more important. Last semester we didn't talk about valves in the sense that we talked about them as normal. This time we're going to talk about abnormal valves, and I'm going to specifically concentrate very heavily on the actual pressure volume waveforms that are generated by the valvular abnormalities and how the medications that we give patients can actually alter that. What actually holds some of the valves, which is the aortic and pulmonic valve, are basically it's its own intrinsic structure, but the mitral and tricuspid valves, on the other hand, have to be stabilized so the ventricle doesn't blow them open. That stabilization component is partly the papillary muscle and the actual chorda tendineae, which attach them to the valve. Without those struts in place, significant pathophysiologic conditions will start to occur, and actually it's one of the most important things of picking up ischemia is knowing this kind of strut malformation that occurs. Then you have to know about the elastic conduit to accept volume, which is what we're talking about in this case is the aorta, okay, and the pulmonary artery. They had a very interesting study many years ago when they first thought of actually trying to replace an aorta, and the first thought was let's put a rigid pipe in. They put a very rigid cloth material into the dog, and the dog died within 2 heartbeats. Scratched their head and like, okay, what happened? So they did it again, another dog. Same thing happened again. Then finally said somebody, you know, the heart is very efficient. The efficiency of the heart is around 70%, versus your car engine has an efficiency of around 10 to 15%, and it's a really good quality car. Okay? Most cars actually have an efficiency of about 5 to 7%. So what makes it different? Okay? Well, the difference is that the heart is pumping into elastic tissue. When the volume is being pumped out of the heart, it goes into another chamber that accepts that volume with less resistance as a consequence, so the heart can work more efficiently. Versus your engine, it has to work against steel pipes that are rigid. They don't give. Okay, so the efficiency drops off, but you're using all that energy against resistive workload. So these elastic conduits, which is especially the aorta, are critical for accepting the volume out of the heart efficiently. Okay? Please do not misunderstand this concept. Okay? It has nothing to do with what maintains blood pressure. Okay? What maintains your blood pressure is not the aorta. That's an elastic conductance vessel. Okay? What maintains your blood pressure is resistance at the arterial level. Okay, so anybody, when they start talking to, say, a hypertension, we're talking about the arterioles mostly. Okay, whatever regulates the arterioles. Now you can actually come back and say, well, Dr. Nolan, you know, what happens if the person's low on volume? Well, that's the case, yeah, that's hypovolemia, but that has to do with the capacitance vessels on the venous side, which accepts 80% of the volume. So if you really don't have enough there, guess what? The whole body is going to be depleted, and I don't care how much you restrict it down, you're not going to get enough of a blood pressure. That's a separate issue. But the actual aorta does not have anything to do with the blood pressure in the sense of controlling it. Okay? It really just is a conduit that allows blood to come in out of the heart and makes the heart work efficiently. As you get older, the elastic conduit, which is the aorta, gets stiffer with time. And if you eat a lot of calcium, not so much calcium, but a lot of fats that end up developing a lot of cholesterol deposits in your aorta and you get calcifications, then you get hypertension because the resistive workload goes up on the heart, so the heart has to work harder to get the volume out. Okay? We do have a very self-contained circulation. It seems to us like it's so easy to understand that. But it wasn't until Harvey in the 1700s that they finally figured that out. All the doctors and all the people that were taking care of people before the 1700s all thought that the blood just pumped out of the heart and went into somewhere, and then it sort of came back somehow. And they had all sorts of very fancy theories, phlogiston theory and all these other things. But we actually have a self-contained circulation where the blood goes in the heart, goes out the heart, goes out the conductance vessels, goes through arterioles, capillaries, comes back through the veins, venules, and it comes back to the heart again. So it's completely a circle system. That's a very important concept that you always have to keep in mind when you're talking about delivery of oxygen, delivery of anesthetic agents. Okay? So we'll get into that in more detail. Now, one of the things that we're going to teach you in pathophysiology is to go to the next step, is the application of what happens when we convert people from spontaneous breathing into mechanical ventilation. The point of actually letting somebody breathe spontaneously is actually very good. When you take in a deep breath, it actually pulls blood back from your legs up into your chest. Because when you take in a breath, you cause a negative chest pressure to develop, and as a consequence, you pull blood from your brain as well as from your lower extremities towards the heart. Converting somebody into a mechanical ventilation, which you put positive pressure, is very detrimental, okay, because it actually prevents blood from returning to the heart during that cycled portion of the breath. Okay? And it actually can become so significant that you can have complete cardiac standstill in certain conditions. And we'll talk about those and where you have to be really, really careful and aware of so you don't get yourself into trouble in the clinical area. And of course, the heart is highly regulated. It has, of course, sympathetic, parasympathetic function. We'll talk about those. And also hormonal regulation ultimately takes place as well. This is your cardiac skeletal muscle. This is this really not really readily available. I've never seen a model of it, so I had to draw it for you. So here's what you have. You have the cardiac skeletal is made around the valves initially. And then you have what's called the sinospiral fibers and the bulbal spiral fibers. Okay? You can see how they're rotated, and actually that's a very important concept because it tells you that the heart's not going to contract linearly. This is like the attachment points for your skeletal muscle on one bone to the next. Those attachment points really tell you which way the muscle is going to contract. If you see a spiral in there, what does that mean what the muscle is going to do? It's going to twist, and exactly what the heart does. If it didn't have this kind of architecture, the heart wouldn't be able to twist. Most people think that the heart just sort of does this. Okay? If you ask a person, give me a description of what the heart does, and they'll say, oh, it does this, it squeezes. It has nothing to do with that. It does this. Okay? My little finger goes down, that's the bottom of the apex of the heart. As it comes up, it rotates, and so it does this kind of motion all the time. Okay? And you can get that motion to accelerate, okay, or you can get it to twist, okay, depending on the conditions you're in. That needs to be visually in your head because it begins to change the EKG pattern that you see on your screen. Okay? If you have a heart that can float and rotate, you're going to have electrical activity that rotates and changes. And that's called electrical alterans, which is something we see with pericardial tamponade or pericardial fluids fusions. Okay, so this is the ultimate structure that's underneath, and these are extremely critical for holding the valves in the proper position. The gross anatomical studies, of course, are important. And looking at the way the heart is set up in your chest is, of course, important. If you have to do a pericardiocentesis on somebody, or as the heart surgeon enters into the chest, you want to know what you're looking at. The way we're structured is that we have the right side of the heart is anterior, okay? And I think about that from a standpoint of survival, okay? If somebody punches you with a solar plexus, the reason that the fighter's doing that is he's causing fibrillation of the heart. People really fall pretty hard when they fibrillate, okay? You're down in about 2 seconds, okay? You'll see the person's eyes roll up in their head and they'll just be down on the ground. Most people then come right back out of the fibrillation and they sort of wake up, okay? But basically you have induced a short-term V-fib or V-tach, okay? Now, you have to ask yourself, wow, that's pretty severe, and it is. I mean, you're punching the heart through the chest wall. But the reason the person doesn't die is that you're not fibrillating the left side of the heart, you're mostly fibrillating the right. Okay? So if we had the heart flipped over the other way and we had the left heart in front, a lot of people would be pretty dead. Okay? So the left ventricle is very protected by your vertebral body in the back and very heavy-duty ribs in the back. So the likelihood of somebody fibrillating if you punch them in the back is pretty low. They may fall from injury, from pain, but they're not going to fibrillate. So it's the anterior portion of the heart that you're looking at. Now, the anterior portion of the heart is provided by the circulation pattern by the right coronary artery, okay, partially. Okay? You have the inferior wall, and portions of the anterior wall are by the RCA. The RCA also develops and provides blood flow to the posterior portion of the heart, and it's most people are 80% dominant of the RCA. There's only two main coronary arteries that come out of the aorta. Remember that? RCA and left main. Okay. Left main breaks off into LAD and circumflex. The LAD branches into D1, D2, and more if you need to, and it provides basically the anterior wall with most of its blood supply. And when you want to monitor it, you're looking at V1, V2. If you do the circumflex, which is a lateral wall, which is the left ventricle, you're looking at mostly V4, V5, V6, V5 being the most prominent way of monitoring the left ventricle using the circumflex artery. Now, the important structure that I expect you to know, and this is you have to know how the aorta comes off. Okay, you have the anatomical structures from superior, which means cephalad, to caudad. The acronym is PAM-T. PAM-T. Pulmonary artery is the most superior. Pulmonic valve is the most superior. Okay, aortic valve is next. Mitral valve is next. And tricuspid valve is the most caudad. Okay? Now that's PAM-T, going this way. Now here's how I want the other way to remember it, and they've been asking this because echo is becoming important. What is anterior to posterior? Here's how I want you to remember it. Pat me. Patting my chest, okay? I'm not patting my head, I'm patting my chest, okay? So that's PAM-T, okay? Pat me goes from anteriorly is a pulmonary valve, aortic valve followed, okay? Tricuspid valve, and the most posterior valve then is the mitral valve. Okay, so most posterior is the mitral valve, okay? Which is, when you look at it under echo, is the easiest one to see. The mitral valve sort of jumps out at you. Okay, the pulmonic valve is almost impossible to see. Okay, it's difficult. Okay, with the new TEs at better quality, we can see them better, but it's still difficult. Okay. All right. I also expect you to know the aorta, the actual aortic arch. Okay, how it branches into the innominate artery. Okay, and then it branches into the right common carotid artery and into the subclavian artery. Okay, and then the left has, on the other hand, separation of the left common carotid artery, and then the left subclavian artery, and eventually the vertebral artery coming off that. Okay? So I expect you to know those kind of structures so you're ready for the exam. Okay? The reason I expect you to memorize that level of anatomy for pathophysiology is because we're going to talk about dissections, okay? And you have to know the aortic arch anatomy. Okay? So you have to really understand where the blood flow is going, what portion of the brain it provides, what do you see if you occlude it, what kind of things would you see in your peripheral arms if you occlude an artery or compress it. So those are the kind of things you need to know. The pulmonic artery splits. This is a poor picture. It actually splits almost into a T, and it gives both the right and left pulmonary artery its blood supply. Now the right atrium is where the volume is coming back to the heart, and the right atrium is basically composed of three major veins coming back. Okay, so this is a favorite exam and board question. Okay, they can ask you three things. Okay, one, they can tell you that the superior vena cava, inferior vena cava, and what's the other blood vessel that's returning deoxygenated blood to the heart in the right atrium? Coronary sinus. Very good. Okay, The superior vena cava, in comparison to the inferior vena cava, has a lower SVO2, which is a lower oxygen concentration. The reason being is because the brain extracts a greater percentage of oxygen that's delivered to it. The brain extracts 50% of oxygen delivered to it. The heart extracts how much? 70 to 60%. Okay? So which one's going to have the lowest SVO2? Coronary sinus. Okay? When you mix it, okay, which is another trick question I saw them ask, which I thought was kind of silly, but the inferior vena cava is going to have the highest SVO2. So when you put the actual oxygen in the atrium, it's going to be diluted down somewhere that's in between the superior vena cava saturation and the IVC. Because the coronary sinus does have desaturated blood, it's the most, but it's the least amount of blood returning. Okay, so it's not going to be like below the coronary sinus concentration. Now, once the blood arrives into the right atrium, it can go through the tricuspid valve normally, or in this case, in about 25% of you, there's a possibility that you may convert a valve that's closed normally, but may actually open. We call that a patent foramen ovale, also known as a PFO. Okay? 25% of you in this room have a PFO. Now, does that mean that you notice it or even have it in the sense clinically? No. About 2% of you actually have clinical significant possible murmur. But the rest of you that do have it are not going to know you even have it. Even if you had the best person listen to your heart, you would not hear a murmur. The reason you don't hear the murmur is because normally the left atrial pressures is higher than the right atrial pressures, and that basically keeps the valve closed. Okay? Now, that's really an important concept, okay? Because I basically just stated to you that the left atrial pressures have to be higher than the right atrial pressures for that valve to stay closed. Under anesthesia, when we put people under general anesthesia and intubate them and put them under positive pressure ventilation, if we do an excessive amount of positive pressure ventilation, we begin to impair the pulmonary outflow, because we actually begin to cause constriction of those blood vessels by direct compression. So the right ventricular pressure is higher. Okay, so what happens to the right atrial pressures? They go up. Okay, and then your volume return to the left atrium actually falls. So you start depressurizing that side, so then the PFO opens. So on positive pressure ventilation, especially if you give too much tidal volume, you can actually cause a PFO to open. Okay? Now, the other thing that's important is that these coronary sinuses actually allow for the venous return to come back from the ventricle. Okay? It's basically heavily deoxygenated blood, but what's really cool about veins is that they don't develop atherosclerotic disease. That's kind of unique, right? Only arteries do for some reason. Okay? We don't really know why. What's interesting is that sometimes when you have extensive three-vessel disease, especially if you have left main disease, if you do what we call the normal antegrade cardioplegia, okay, which means we inject, after the cross clamp is placed, we actually put hyperkalemic solution that's also cold through the coronary arteries. But if you have a very heavy restriction from a left main, let's say 80, 90%, is the heart really going to get that high dose potassium in high enough amounts and enough cold value to really stop the heart properly? And the answer is no. So in other words, the heart basically stays partially unstunned and basically starts continuing to contract. And then that person has a much higher risk of developing a myocardial infarction during bypass. So what we do instead is, when we see that person having extensive disease, we put this retrograde cardioplegic catheter through the right atrium and then seed it into the coronary sinus. Because I just told you the veins don't have atherosclerotic disease, even if you have 80% occlusion in the left main, when you give this solution through the retrograde fashion, it pushes it back through the venous system, goes back to the arterial system, the capillaries, and basically shuts off the heart very efficiently. So that's when you will see this. Okay? You will be asked about retrograde catheters when you get to open heart. So guess what? Better learn it now, because when I first was asked what a coronary sinus was, that's something they never talked to us in medical school about anatomy. Okay? Because, you know, who cares, right? Well, we did care. And then especially you had to look for it under TE. It's actually very easy to find under TE once you know what you're looking for. The right ventricle is the workload that's going to, workhorse that's going to give the volume into the pulmonary circulation. What you're looking at is the tricuspid valve separates this from the right atrium. It uses papillary muscles. What's unique about the tricuspid valve is it has 3 papillary muscles because it has how many leaflets? Tricycle? 3 wheels. 3 wheels, 3 valves, okay? So it's a tricuspid valve, okay? So it has to have 3 papillary muscles and 3 valves, okay? This system is very efficient in the sense that it's usually against a low resistance workforce, so it doesn't have to really pump against a lot of resistance. So the ventricle doesn't stay very thick, okay? It stays thin. In comparison to the left ventricle, it's much more compliant, okay? And so in other words, guess which portion of the heart is more likely to be squeezed by outside forces? Right side. Okay, so tamponade affects right ventricle much faster than the left ventricle. Okay? The right ventricle in this picture shows you, it looks like a pyramid shape. If you were actually to fill it with a mold, it actually has a pyramidal shape to it, which is kind of cool. The heart, if you look at a pediatric kid, like say a 3-year-old or less, the ventricle actually looks completely the opposite. The right ventricle under 3 is actually hypertrophied. And the heart remodels itself after the age of 3. And you have to ask yourself, why is that, Dr. Nolan? See, everything should be a question. Why does it do that? What happens to a baby in utero? What's it pumping against? The lungs are completely collapsed. So the resistive vessels are very, very constricted down in the pulmonary circulation. So the heart, the right ventricle is actually pumping against tremendous resistance while you're in utero. Okay? So most of that volume is actually going to be expressed through ductus arteriosum and bypass the lungs completely. Only about 10% actually ever goes through the lung. Okay? So all that heavy resistive workload is going to make the right ventricle actually hypertrophy until you're born and you take in that first big deep breath. Okay? If you like doing pediatrics, you need to learn this because if you get a kid who never takes that really big deep breath or never really develops very healthy lungs, then pulmonary resistance is high and the right ventricle doesn't remold. Okay? It stays hypertrophied for the rest of their life. Okay? Eventually, under normal conditions, though, the right ventricle does remodel itself into a thinner, more compliant structure, and then you develop the left ventricle becomes more hypertrophied and less compliant over time. And you can actually see it's got this circular shape to it, okay, which is the left ventricle. This is the left ventricle here. See how it looks completely, that's why it's called concentric. It's around a circle, concentric. And you dump the blood flow into the pulmonary artery. This is a beautiful casting of what the pulmonary artery looks like with the alveolar casting as well. This is one of the, I don't know how people have the time to do this stuff, but it's pretty impressive. And this is actually on a real human being. Of course, died, but it's still pretty nice. What's the important structure about the pulmonary artery is that you have an attachment point here which comes off the left pulmonary artery. Please do not put the right, it's on the left side. Okay, it's actually in the left chest as well. Okay, so when you have to do a dissection injury, this is where the initiation point. Okay, the pulmonary artery is attached pretty much to the back of your thorax, so it's not going to move. Okay, the only thing that's floating up there is the aorta. It's like just basically wagging in the wind. Okay, so what the attachment point to the aorta is this ligament, which is the actual in the child was the ductus arteriosum. So because it becomes a duct, it goes into a ligament, it becomes a ligamentum arteriosum. If it stays open, it's called a patent ductus arteriosum. Okay? But that's the attachment point, usually right after the left subclavian turnoff. Usually indicating to you that it's a descending aorta where you get deceleration injuries and you get dissections that take place, and including aortic ruptures at this level. Usually aortic rupture is lethal. If you have a dissection at this level, there's about a 10% chance you'll make it to the hospital, and only about 10% chance you should actually leave the hospital. The left atrium is the next structure. The left atrium accepts the pulmonic veins that are oxygenated. This is a few examples where oxygenated blood is actually returning in a vein. Okay, so the pulmonary veins are a good board question to ask you. Did they have oxygenated blood? And the answer is yes. Okay. Just be careful. Just don't always answer it because it's a vein. It's oxygenated, okay, or deoxygenated. So once it enters into the left atrium, it then gets pushed into the left ventricle due to atrial contraction during the atrial kick phase. The left ventricle is of course very thick. Okay, it has two papillary muscles because the valve that separates the left atrium from the left ventricle is a mitral valve. The wording from mitral comes from miter, that we use when we look at the Catholic priest when they're in their regalia. They actually have a miter valve on top, so that's where we actually came up with the name. What's important about the structure is the way the overlay is. This is what's called the outflow tract here. Okay, this is the outflow tract here. The outflow tract is an important area because you have the septal wall is on the medial side of it. The lateral side of it is the mitral valve, and superior to it is going to be the aortic valve. If you get the actual septal wall to hypertrophy, it begins to affect the dynamics of outflow and develops what's called outflow obstruction. We're going to talk about that a little later on. Coronary circulation, of course, can be broken down into your left main, which then separates into the LAD and the circumflex, and then you also have the RCA. Now you can do this and you can memorize all this stuff, but you know what? That's pretty much useless when you get to clinical. But what I expect you to do, and I expect you to understand, is the following. You should be able to draw the aorta, something simple like this. Okay, that's your aorta. Keep it simple. That's your RCA, and then you have left main. And then you split this. This is LAD, D1, D2. Circumflex, which is in OM1, OM2. Okay? That's how I draw it before I do any kind of evaluation of somebody's heart. If they're going to go for open heart surgery, then I look at the cath lab. If the cath lab report says, okay, the patient has 80% left main. Okay? So what I do is I go in and I do this. Okay? Then they have 60% circumflex, and they have, at D1, they have 80%. Okay? That's it. That's my cath lab report, without having to write anything down. That's called being efficient with your time. You cannot sit there forever and then convey that information quickly to the next team that's going to take care of it. Now, the reason that's important to also convey to your mind is because immediately when I see this picture, I know that I have to monitor two areas. I have to monitor this here and this here because these both are affected by the left main. Okay? So I'm going to watch V5 for ischemia, and I'm going to watch V1 and V2 for ischemia. Okay? If I had a cath report saying that it was the RCA, then I'd be looking at 2, 3, and AVF, the inferior wall. That's why you want to sort of put this stuff together so you can now take care of somebody properly. You're not just going to routinely monitor any way you want. You want to monitor in a certain way. Okay, your coronary venous drainage is important, like I just told you about the retrograde catheters. It does allow all the blood flow to eventually reach the coronary sinus, which then dumps it back into the right atrium. Your systemic circulation versus your pulmonary circulation is, of course, very different. You can see that the pressures are very different. The mean arterial pressure on the pulmonary side is around 15. The mean arterial pressure usually on the systemic side is around 100. So it's a pretty significant workload difference. The reason you're seeing that is because the lungs are able to accept the volume very easily with low resistance. If you look at the actual cardiac workload that you have here, the right ventricle is actually working a lot less hard than the left ventricle. Okay? So it's also more likely not to develop ischemia. The right ventricle also gets perfused continuously during the whole cardiac cycle, versus the left ventricle only perfuses during diastole. Okay? Microanatomy of the heart is where we stop here. We'll give you a 10-minute break, and then we'll come back and restart this.